There is a common belief that coronary artery bypass surgery has now totally replaced angioplasty and stents. The ACC/AHA clinical guidelines of 2021 and European guidelines of 2022 have recommended that the decision should be made by the heart team based on the clinical indication. In an acute situation like an acute myocardial infarction with ST elevation myocardial infarction called STEMI, the decision is very clear cut that we have to revascularize the culprit artery. So angioplasty and stent of the culprit artery is the indication in that situation. However, if there are mechanical problems like ventricular septal defect or rupture or severe mitral regurgitation, then the situation becomes different and angioplasty may not solve the problem. We have to do a mechanical solution, that is bypass surgery. In stable ischemic heart disease, the decision is based on two factors. If the left ventricular function is lower than ejection fraction lower than 35%, or if there is left main stem or LAD proximal or ostial LAD involvement. In both these situations, bypass surgery gives a more lasting benefit than angioplasty and stents. There have been many meta-analyses done, and all cases, all-cause mortality, myocardial infarction, stroke, and repeated revascularization have been studied, and in all these situations, bypass surgery seems to be better. Over the years, the surgeons have been doing off-pump surgery, and the worry about the stroke has come down a lot as compared to the previous on-pump surgery. Aortic non-touch bypass surgery using both the internal mammary arteries in the Y configuration gives us further safety in avoiding strokes. My take-home message of this talk is that the decision should be made by the heart team and not by the patient, and both modalities are valuable and they should be used intelligently depending on the patient's requirement.